Patil, working as a product manager. We at Emcure Iowa division maternize our core brand and epitome of quality and success. We would like to thanks to iHERA team for giving us this opportunity to host this scientific webinar and be a partner for this wonderful academic initiative. I would like to thanks to Dr. Ved Prakash, Dr. Sanjay Shukla, and Dr. Charudatta Joshi for arranging this webinar. And special topic is no, the known and unknown tales of an oocytes. Now, I would like to, with me, my colleague is there, Rajeshwari. Now I'm going to hand over to her. Rajeshwari.
Thank you, Nakul. Good evening, faculties and doctors over, embryologists over here. Just I'm going to introduce Dr. Ved Prakash. So he is the lab director, South End Fertility and IVF Center from NCR. Dr. Ved Prakash is the founder of International Human Embryology Research Academy, and he is the past president of Academy of Clinical Embryologists. Doctor is also a faculty, having a faculty and fellowship in ART from Amity University, based out at Noida. And Doctor has...
We can move forward, please. Only 2 lines.
Okay.
Okay.
We have with us Professor Dr. Sanjay Shukla, sir, the senior consultant embryologist based out at Mahatma Gandhi University, Jaipur, working in the field of human reproduction since 1998. We have with us Dr. Charudatta Joshi. He has a special training in ICSI, IVF and sperm from Belgium, and sir has done a special training in PGD from Germany and training in laser assistant hatching from Belgium. So
Rajesh,
I welcome.
Sorry to interrupt you. Can you put in a slide share mode? Thanks, Rajeshwari.
So I would like to welcome all the 3 of the speakers for today's program. So we have with us Dr. Sanket Dumal Satya, senior clinical embryologist based out at Mangalore, editorial board member of Journal of JBRA Assisted Reproduction, and his area of interest is male infertility and cryobiology. And welcoming Dr. Rahul Sen, currently working as a consultant embryologist in Nilkant Fertility, Jaipur, based out Rajasthan. He is the treasurer of ISA Rajasthan chapter and published papers in national and as well as in international journals. And I would like to welcome Dr. Akash Agarwal. He is a scientific director from Hegde Fertility, based out at Hyderabad, member of National and International Fertility Organization, and his key interest is in cryobiology and male fertility treatment with surgical retrieved sperm. So once again, I'm welcoming you all for this wonderful session.
Yeah, thank you so much, Dr. Rajeshwari. And firstly, good evening to all. And on behalf of iHERA, I would like to wish all of you a very happy new year. And yeah, today in this webinar, we'll be discussing in detail about the oocyte. So we categorized into 2 lectures initially, one which deals with the cytoplasmic features, and we have Dilip with us to talk about it, and one extra cytoplasmic features, which we have Gaurav Kant with us to talk about it. Then we have a panel followed the lectures. We have a panel discussion on the same thing. And now I would like to invite the moderator for the first session. Can you have the CV, please? Yeah, already introduction is over. Charles, sir, please take over. And I would like to ask you to introduce the first speaker.
Yeah. Good evening, everyone. On behalf of iHERA, I welcome you all. It is always a pleasure to be part of the event, and it's always useful for all of us. So today, the theme is of oocyte, and we all know that everything starts from the oocyte, and the quality and generation and maturity and so many things to be discussed about oocyte. So for this, I would like to invite our first speaker, Dilip. Can I have the CV, please?
Yes, we are sharing.
Yeah. Yeah.
Visible?
So, yeah, it is visible now. Thank you. So, Mr. Dilip Kumar, I would like to invite Mr. Dilip Kumar. He is currently working as senior embryologist with Milan Fertility Center, Bangalore, and studied human sperm extensively based on sperm kinetics with the help of CASA, and authored chapters in Infertility Manual and Atlas of Human Embryology and so on, so many things to his credit. So it's presently executive member of Academy of Clinical Embryologists India. So without getting you waited for further listening to him, I would like to invite Mr. Dilip Kaur. All to you, please.
Thank you, Charles, sir. So, shall I share my screen?
Yes.
Yes, you can, Doctor.
Okay. Right. Good evening, everyone. So, thank you for the IR for the opportunity to be an academic session. So, everyone knows that the oocyte is a highly specialized cell, and it is very large cytoplasm. It contains the stock pile of cellular material needed for the development of the embryo. So today I'm going to discuss presenting about the cytoplasmic feature of oocyte oplasm and metaphase place. So this, everyone knows that how the oocyte looks. Every embryologist, every day they see the GBs or the M1 and M2. So every day it is like routine work. So how the normal oocyte looks like. So generally the size of the oocyte is around 110 to 120 micrometer, and it is a completely nuclear maturity. So obviously when it becomes the M2, it is a totally nuclear maturity, and round clear zona pellucida and the small perivital space, and moderately granular cytoplasm. This everyone know that how it is looks. But I'm more concentrating about how the cytoplasmically the oocyte look like. So here, when you go to the cytoplasmic parameter, the oocyte oplasm cytoplasmic parameter. So generally we observe there are fragile in the oocyte, there is a granular, there is a HCR and refractal bodies. I think this all the routine part of the embryologist. I think even like every day, it is very tough to say that quality of oocyte, how it is look. Doctor says that how is the quality of oocyte looks, that we need to say good. If you say bad, so they say that every time you say the same thing. So definitely the quality of oocyte helpful for the developmental competence for the getting the good blastocyst and pregnancy rate. So we are going to one by one briefly how it's served. So coming to the granularity in the cytoplasm. So normally when you see that how the cytoplasm look is a fine uniform define the granulation in the cytoplasm. So I think you can see the picture over here. There's a very dense cytoplasm, and here one more is a brown egg actually. So a lot of observation I seen in the time-lapse image. So the crystal clear cytoplasm and is very, very important to manage entire organelle in the cytoplasm. If there is a big granulation in the cytoplasm, I think, I say that there is a wave motion in the cytoplasm. So there is a movement in the spindle, there is a movement in the organelle, there is a movement in the mitochondria. So every movement, the cytoplasmic wave motion is very, very important for the developmental competence. When there is a big granular in the cytoplasm, I think it is really struck somewhere for the competent to grow for the blastocyst. And here, one of the study I seen that high pesticides exposure have the high risk of granularity. One of the papers shows that the farmer using the more pesticides, they have more exposure to the granularities, and even cytoplasmic immaturation will be causes of the granularity. Increase the chromosomal aneuploidy, 52.5%. That study shows that the granulation will be causes, and correlation of localization of mitochondria. So So mitochondria is very, very important as an energy source for the development. When it will be effect on localization of the mitochondria when there is a larger number of the granulation, and even the patient age and the stimulation will going to affect on the granular in the oocyte. So here you can see that the granulation and even definitely the embryonic development, the pregnancy rate and cleavage rate, birth rate, everything, there is a paper shows that it will affect if the percent of granulation is too high. So some of the research reviews shows that the Ebinor et al. In 2008, there is a low fertilization rate, and even 2008, there is a survival and impaired development after the cryopreservation because of there is impaired on the proper metabolic activities if there is a bigger granulation. And even there are some papers says no correlation, but some papers says that most of the papers says that there is effect on the fertilization rate, embryo formation, and pregnancy rate. So then moving to the aggregated, the smooth endoplasmic reticulum. So generally it appears in the M2 stage and disappears in the PN, and the pronucleus is slightly bulged, flattened, translucent, disc-like, and large clustered tubular smooth endoplasmic reticulum, and surrounded by the mitochondria and granular containing tiny vesicles localized in the cytoplasm. So you can see here the center portion of the cytoplasm is the smooth endoplasmic reticulum. So generally the smooth endoplasmic reticulum is around 10 to 18 micrometer, depends on the dosage and duration of the JRNH, also causes the SER. And calcium activation, oocyte activation, abnormal mitochondrial respiratory activities. So when there is abnormal mitochondrial respiratory activity, it affects on oxidative phosphorylation and overall metabolic activation trigger in the oocyte. And so chromosomal segregation error and abnormal cytokinase and microtubules and Beckwith-Wiedemann syndrome. So I think this is a major, I get shocked by seeing that Beckwith-Wiedemann syndrome is causes if there is a bigger percentage of smooth endoplasmic reticulum. So these are some of the paper I go to that there is a causes of the SCR. If there is a bigger SCR, there will be causes Beckwith-Wiedemann syndrome. So it will going to be effect on the like overgrowth and abdominal abnormalities, low blood pressure, and increase the cancer risk. These are some of the problem I observed in one of the paper. So coming to that, oocyte, the endoplasmic reticulum cluster originate with the blastocyst. Also, it will impair on implantation. So when you see that in the time of ICSI, you need to segregate the smooth endoplasmic reticulum, the granulation, so that in that we need to segregate, we need to select which is the best oocyte or best embryo for the transferring. So definitely the endoplasmic reticulum, it will impair the implantation, and you need to take a special interest for the SER oocytes, right? So what is the cause for the egg to have the smooth endoplasmic reticulum? So when you see that there is a high E2 level could one of the cause for the SER formation. And even the serum E2 level on the day of SCG administration was significantly higher in the SER positive cycle. And what are the effect of the endoplasmic reticulum? Here you can see that it is going to affect on the fertilization rate and cleavage rate, and it will going to positively affect on the pregnancy overall. So this is of endoplasmic reticulum. These are some of the picture where you can see the SER, the centrally localized SER in the cytoplasm. And literature review says that lower fertilization rate, lower blastocyst formation, and obstetric problem, birth weight, and even ICM formation in the blastocyst also lower. I think every time when you're doing the ICSI, please segregate the things so that we can know that what is the developmental competence of the East SER or the granulation and all. Even the miscarriage rate will be going to increase if there is a SER, and even normal development is very, very difficult in newborn with the free of the malformations. So here there is a 183 babies, and in that 171 LT, 8 malformation, 3 neonatal death, and 1 still birth. So these are some of them. Then coming to the fragile cytoplasm in the oocyte. So generally when you see when you do the ICSI, you can observe there is a funnel shape formation. So where you can draw up, when you're coming back, you can see the funnel. So if there is most of the time when you not create the funnel, there is a term like fragile, you can see the degeneration. That means that ulama is not so resistant to like accept when it is not, it will make a bigger hole. In that time, the cytoplasm will be come out from the ulama and causes for the degeneration. So it's responsible for the sealing breach, demonstration for the sudden breakage, and no resistance upon the needle entry and co-exit with leakage of cytoplasm. So it will going to reduce when presence of the fragile cytoplasm, you can reduce the ability of the second polar body extrusions and subsequently decondense in the cytoplasm and forming the third pronuclei. So these are the loosely selectivity of the intact membrane toward the ion and other substance integrity, and even the cytoskeletal complex affect the zygote ability formation with the fragile cytoplasm. So even the number of cleavage embryos, it will significantly go lower. The more gonadotrophin administration may be one of the causes for the fragile cytoplasm, and lower estradiol level on the day of SCG. So coming to the vacuoles, you can see that vacuoles, maybe like you get a bit of confusion with the vacuoles and SCR. So here vacuoles is like spontaneously and diffusion, and this is causes from the SCR and Golgi aperture. Surrounded by the membrane filled with the fluid, it should be generally around 14, less than 14 micrometer. And here you can see a formation of the vacuoles. The vacuole can arise spontaneously around the extrusion of the first polar body. The vacuole can be formed from the pre-existing vesicles derived from the endoplasmic reticulum and the Golgi aperture. The vacuole can be generated unintentionally by the ICSI also. So these are some of the chances it will be. And occurrence and developmental consequence of the vacuoles. So there shows that 3.9% of the chances of vacuole formation. And when you look into the fertilization, normal and abnormal, there is a 68 to 65% of variation. And the vacuole oocyte have the blastocyst formation is keep it around 12.5% compared to the unaffected, that is around 50%. So when see the literature review, so correlated with the cryo survival and developmental of embryo will be go down, and greater pregnancy, biochemical pregnancy, lower pregnancy rate. And some studies say no effect on fertilization and embryo quality, but pregnancy rate will be go down and even lower fertilization, some papers. So these are some of the vacuoles. There is a single and multiple vacuoles you can see here. Then refractal bodies. So another, the cytoplasmic factor, it is caused by the oxidative stress of the lipids and proteins, the incomplete degraded of the autophagocytosis material. So this is where you can see this is the one with the refractal body. And so this is lipofusion also we can call, and it is 570 to 670 nanometer in the size. So in that literature review, you can see that it's not going to affect on the fertilization, embryo quality, and implantation rate. Chances of it going to reduce some of the pregnancy rate. 1 or 2 papers is shown. So these are the vacuoles. What I'm going to show you, the small dot over here, these are the vacuoles. Refractal bodies. So then coming to the parthenogenetic activation, I think it's not in the cytoplasmic, but I just add on over here. So some of the key element causes, the ethanol, calcium ionophore, electric fluid stimulation, and M2 cell division, eye vacuum pressure. So eye concentrated, allelic, these are some of the induce the parthenogenetic activation in the oocyte. So this is overall when you see that how the cytoplasmic abnormalities in the oocyte. So right, so this till now everyone every day you observe with a microscopic and inverted microscope what all till now I told you. But what about organelle? When you inject the oocyte, when you aspirate the cytoplasm, do you know that how many organelles will come with you and how going to its effect? So we need to go a little bit deeper that how the organelle will going to play the role in the cytoplasm and fertilization effect. So when we are taking the picture, like when we taken the oocyte with a bigger like electronic microscope, here you can see that distribution of organelle GV. In there, the organelle displays the non-homogeneous distribution. So in the GV, there is the allo formation. So organelle-free cortical area, this is the allo formation, disappears as oocytes re-enter to the meiosis. The periphery, that is a 10 micrometer from the ulama to the center ratio of the organelle density was significantly lower. So there is a GV and GV surrounded by the organelle. There is a halo formation in the periphery. And here coming to the M1, and this is the MO. In this two, you can see that the spindle positive M1, M2 site organelles were dispersed the homogeneously throughout the entire volume of cell except in the meiotic spindle. So once the nuclei, which is there in envelope of the GV where the chromatin condensed, once it is start opened, all the organelles will be dispersed homogeneously throughout the entire volume. And the periphery to the center of the ratio of organelle density was significantly lower compared with M1 and M2. The major relocalization of the organelles occurred during the transition of prophase to metaphase of first meiotic division. So these are some of the picture where you can see here. So this is the GV nuclei present surrounded by the organelles. So mitochondria, Golgi aperture, endoplasmic reticulum, everything will be there. So then once it is dispersed, you can see here the mitochondria, it is going to attach to the endoplasmic reticulum. So these are some of the electronic pictures where you can see that the overall organelle movement in the oocyte. So this is about the morphometric analysis of what is the distribution of the organelle in the position of GV, M1 and M2. So here you can see in the organelle distribution is very, very minimal in the GV, where the most of the organelle will be concentrated near the center. So once it is moved to the metaphase 1 and metaphase 2, you can see that the organelle density will be increased. So maybe there it is helpful for the activation and for the process. So then you can see some of the organelles over here is the mitochondria, endoplasmic reticulum, Golgi aperture, lysosomes, so and the cortical granula and annulated one. So then coming to the major things, so when you are not major concentrated on mitochondria, endoplasmic reticulum and Golgi aperture, the most abundant organelles in the oocyte of all mature oocyte is the mitochondria, because it is a powerhouse. It will give the more energy for the oocyte activation, even the calcium oscillation once it is oocyte get activated. So generally it is a 0.3 to 0.7 micrometer. The average diameter is around 448 nanometer. So here you can see the mitochondria, and here you can see that how the mitochondria are going to bound to the endoplasmic reticulum. So here M1 oocyte, the numerous mitochondria populated at cortical region show that tendency to approach the randomly distributed ER structure. So it is a necklace-like complex formed variable size like a sac, ER decorated with several mitochondria. You can see this picture in here that ER is decorated with the mitochondria. Even here also you can see that. So it is a powerhouse where you can get the more energy. And this is about the Golgi complex. I don't take it too much here. Then you can see that increase the organelle density is supposed to support resource and energy supply for the metabolic activity of haploid. So from the meiosis to mitosis. Once it is meiosis to mitosis, it required a lot of energy so that organelle will be equally distributed in the cytoplasm. The mitochondrial population formed a characteristic complex with ER, which serve as a primary storage for intracellular calcium. So as I told that the mitochondria is have the intracellular calcium where it will boost up, trigger the calcium oscillation for the activation of the oocyte. And major feature of the oocyte maturation is accumulation of the organelles around the prophase nucleus. The collapse of the nuclear domain and fragmentation of the nuclear envelope at the germinal-vesicle breakdown, the organelle dispersion toward the periphery of the oocyte during the metaphase meiosis 1, the progressive integration of the Golgi aperture accompanied by the deposition of the CG in the subcortical, the cortical granula in the subcortical area, gradually rearrangement of the endoplasmic reticulum and mitochondria complex. So then moving to the metaphase plate. So what is the metaphase? Say that all the chromosome, the base or fully, once it is like a decondensed the GV, so all the chromosome pairs are fully condensed and attached to the meiotic spindle aligned in the center. So what are you going to see here? The center we call going to be metaphase plate, right? So each spindle was further characterized based on whether all the chromosomes were aligned on the metaphase plate or if chromosomes were misaligned. So misalignment was denoted as any case where there greater than 2 mm displacement, at least one chromosome from the metaphase or epitheral plate. So in the reconstruction from the polar range, we defined the chromosome D position as being normal when two sets of the concentric array were apparent. If there was a deviation from this, as indicated by peripheral displacement and absence of complete inner ring, they were classified into. So then moving to here, you can see the picture where the confocal microscopic image of the spindle, and you can see the green is a metaphase plate. The spindle visualization change during the maturation. And this is meiotic spindle, where you can going to observe the meiotic spindle present in the next to the below the, keep it around 30 to 40 degree angle of the polar body. So the presence of the spindle is give the chances of fertilization. And so the meiotic spindle close to the polar body was correlated with the fertilization and cleavage rate. High degree of misalignment between the meiotic spindle and first of all increase the risk of fertilization. Pregnancy rate very strongly correlated to the normal morphology. So thank you very much.
Thank you, Dilip. Nice elaboration and very minute details are covered.
Thank you so much.
I would just like to ask you one thing.
Yes.
That this all spindle and everything, this is, you also know that it's more of a technical and research kind of thing. For a general person working, like the junior embryologist or an embryologist working in a normal lab,
Right.
where they don't have access to all these things.
Right.
So what do you think that what he or she should see to satisfy or to tell question asked by the clinician that whether oocytes are good quality or bad quality? So what are the basic parameters you will see in an denuded oocyte so that you can label it that, okay, presumably, probably this is the better one and this is the not better one?
So when you look into the cytoplasmic abnormality, like the oocytoplasm, the major one is granulation. What is the percentage of granulation? And second one is SER. And third one is vacuoles present. What is the percentage of vacuoles, whether it is a small or big? And what is the fragile cytoplasm? I'm talking about internal cytoplasmic characteristics. So these are the major thing. Maybe we can note down and say that maybe like if you not land up with a good quality of embryo, maybe these are the cause.
Yeah, so these are the characters which one can see even on inverted scope also on manipulator.
Exactly.
Correct.
Yes.
So what interpretation they should take out of it? That they should tell what they should tell to the clinician. That is what is my question. Whether they are good, it's a bad quality, or you may expect fragmentation, or there will be no fertilization.
So I'm saying that you will get a fertilization, you get a good embryo with all these abnormalities also. But getting the pregnancy is a big question mark over here.
Correct.
To say that even though it's going to fertilize, it's going to get an embryo. So because of the pregnancy, we may like analyze why we will not get the pregnancy. Maybe like because of SCR, because of the vacuole, maybe this is the reason. Maybe we may not get the pregnancy.
Why I ask you this question is because this is the question which was I'm listening from last so many years. The very first thing after pickup, clinician comes and asks, how is the oocytes? Right. So I think this is probably the answer to that, okay, these are the things, so we can expect fragmentation.
I think we need to keep the evidence to show that we need to take every picture, every patient picture to prove that. Because see, every day if you say that oocyte quality is not good means maybe clinician feel bad that somewhere is lab is not good. Finally, they put on embryologists. So instead, I think we need to have the evidence of every patient and we need to show that this is the quality of oocyte. But if cytoplasm is very good, I think it is very like we also very happy to do the ICSI.
Mm-hmm. Okay. Do we have any question in chat box? No, I could not see any question for Dilip.
Yes, I have one question for Dilip.
Yes, okay.
Firstly, to answer Charu sir's question on a lighter note, to answer the clinician, there are three things. Either the all are good, second is all are bad, third one is a mixture, good, bad, and ugly. So these are the three answers which having said that, and coming to Dilip's question, you showed a very beautiful picture illustrating the organelles in the GV, M1 and M2. So if you look at it clearly, there's a very clearly they mentioned the number of mitochondria which is getting doubled in each stage. So how does that happen? In GV, what is the differences between with respect to mitochondria with respect to GV?
Yes, I tell you. So mitochondria is not going to change its number. from GB to metaphase 2, the mitochondria quantity, it will be remain same. But major thing is the distribution of the mitochondria will be playing. So generally in the GB, it will be in the clusters of the germinal vesicles. Once it is the breakdown, then it will be dispersed, but there will not increase or decrease any mitochondrial load in that. So it's not going to rise or decrease. It will be remain same from the GB to metaphase 2.
Yeah. Just to extend the point, it mainly distributes with respect to the polar body as well. It is like bottleneck theory, which is already predetermined in the GV. There, then it is sub-distributed with respect to the cytoplasm and the polar body, which is getting extruded.
Exactly. So we all like abnormalities. So now I said that if it is a granulation and all, the proper distribution of mitochondria will not happen. Localization will not happen. So now even though it fertilizes, developmental competency will. So maybe like abnormality causes for the improper localization of the mitochondria and the other organs.
So there are two questions in the chat box. Charu sir, would you like to take them? Sir, you are mute.
So I can.
Yeah,
so
you can go ahead. You can go ahead.
I'll go ahead. So
Yeah,
now, so Jackie says that the oocyte quality is average, but blastocyst formation is sometimes good. However, yeah, I'll say that even though sometimes oocyte quality is good, you get a good blastocyst. What is the outcome? What is the pregnancy? See, any embryologist, we need to see that what is the final pregnancy.
This is where I asked that question, because once you label it that okay, madam,
I also face so many times, sir.
Then you get a very good
I also face same. See that
pregnancy
quality is very average. We get a blastocyst. Say that how you get the blastocyst with oocyte quality is very
correct.
So it all like molecular level, and even we need to see the what is the end result. The pregnancy is like ultimate. Even live birth is ultimate. So that we need to see that.
Yeah, there is another question: how to access quality of oocyte. I think that we already have discussed. The characters which you will see in an M2 oocyte, whether it's a good quality or bad quality oocyte. Any other point you want to add in quality of oocyte assessment?
So I think majorly I covered.
Yeah. So if there is no other question, can we close down this session?
Yes.
Sure.
Right, sir. First of all, sorry to interrupt you. For this webinar, total login is almost 600 login happen, and total registration for this webinar 476. It's a huge number.
Wonderful.
Yeah.
Great.
Thank you.
So with this, thank you, Dilip, for such nice presentation and elaborate discussion about this. So hand over to moderator back for our next.
So thank you, sir. Thank you for iHERA for the good academic platform. Thank you very much.
Thank you so much, Charu sir. Thank you so much, Dilip, for that excellent presentation. Now,
Sanket sir, can I jump in? So to answer a very, shashwat prashna that the clinicians continue to ask us, and what Charu sir was trying to address, is that what we are seeing in the oocytes is just the morphology.
Yeah.
We do not know the potential, the competence of the oocyte, and maybe like what are the abnormalities that we observe under the inverted microscopes, like the ACR disk or the central granularity or the extracytoplasmic debris and other features. Despite all, there are two things which define the fate of the embryo. One is that we often tend to avoid transfer of those oocytes, those embryos which are derived from abnormal oocytes. So we do not know exactly. The other thing is that it's not only the oocyte, but also the sperm contribution and the patient's inherent characteristics or the other features like endometrium and certain markers and receptors and biochemical dialogue between the oocyte and embryo and the endometrium. So all these things, they define whether the embryo is going to implant or not. So it's not just one line answer कि okay madam अच्छा दिख रहा है और ये तो बिल्कुल pregnancy देगा. So no one can answer this.
Right, sir. Yes, sir. Rightly said. And yes, we cannot generalize it because we are only looking at a morphological part of it. The competence doesn't rely only on the morphology wise. There are a lot many things which are internally, like molecular level, which has been involved over there, which we really don't know as of now. So yes, sir. Thank you so much for that input. And Rahul bhai, Akash bhai, are you there?
Yes, Sanket, thank you. I'm here, but sorry for my really bad throat. Sanket, if you can.
No problem. Yeah.
Sorry.
Next, I would like to introduce of course, Dr. Rahul is the moderator. Next, I would like to introduce the next speaker, a dear friend, Dr. Gaurav Kant. So, can we have the CV of Gaurav, please? Yeah, currently he's working as a senior embryologist at Akanksha IVF Center. He is the first Indian embryologist to be certified by both prestigious societies, ASTRA and ASRM. And he's also certified by IFS and Global Fertility Academy. He has presented 11 papers in ASRM, ASTRA, and IFSS. And he's also convener for Research Andrology, IFS 2022 to 2022. And also has done the same for the years 2018 and 2020. And he is also blastocyst biopsy and cryopreservation training. He has obtained his training from Barcelona. Without much further delay, I would like to hand it over to Gaurav.
Thank you, Sanket, for the nice discussion about me. It's always a pleasure to listen about me from you. So, can I share my slides here?
Please.
Yeah, thank you. And is it visible to you?
Yes, please go ahead.
So I'm a one who, with you guys, have done something injustice, because today I'm going to talk about something which has nothing to do with the baby at all. It is something which is more like a carrier. So whatever Dilip has talked about, it is more like a satellite which revolves around in the orbit and gives the data. But my data is all about the rocket which actually takes to the sky and deliver the satellite in the orbit. So whatever is there in my PPT, it is basically taken from these three papers, which are very well known and popular. One is by Laura Rinzi, the oocyte. It is there in the iHERA Atlas. Second is the selection of competent oocyte by morphological criteria for ART by Safet Ozturk. And the third is does morphological assessment predict oocyte developmental competence, a systemic review and proposed score by Alessandro, which is recently published in 2022. So there are lots of factors being discussed by the Dilip regarding the cytoplasm. There are other factors also, like the polar body, zona pellucida, and the parvate space, which I'm going to talk about. So let's talk about the zona pellucida. So zona pellucida is basically made. I'm going to little basics, which everybody should also know that what are types of zona pellucida. There are basically 4 types: 1, 2, 3, and 4. So out of those, the zona pellucida 1 is the one which is intertwining between the 1, 2, and 4, 3, and the 4th is the last one. It is basically secreted by the oocyte and the cumulus together to make the zona pellucida outside of the oocyte. Regarding the function of the zona pellucida, it started from the oogenesis to the acrosome reaction to the species-specific sperm binding to the fertilization to prevent the polyspermia to embryo development and finally to the implantation and delivering the healthy baby to the uterus and helping it to implant. So it starts from the primordial follicles only, where the zona pellucida is a very small size thing. As the oocyte grows in the diameter from 20 micrometer to the 80 or 90 micrometer, the zona pellucida grows along 1.9 micrometer. So zona pellucida has a very specific function that it doesn't allow any sperm to bind to it. If you put the other sperm, they don't bind, but there are exceptions to human sperm, like the gorilla and hylobates. They actually bind to the human oocytes. This is a study which talks about and tried to find out which of the 4 zona pellucida is actually responsible for the species-specific zona binding of the sperm with the zona pellucida. So they try to manipulate all with the human versus mice at ZP1, ZP2, ZP3, and ZP4. And then mainly out of all the crux is that only ZP2 is the one which is species specific. And the other role of the other like ZP1, ZP2, ZP3, and ZP4 is basically for the ectosome reactions. So there is the N terminal of the N terminal. Sorry. There is an N terminal of the human ZP2 which is responsible for this. So there are mutations also, as Dr. Charu was saying, that we are not going to deep into studies when we are doing more of lab work. Yes, it is there, but we can define that when there are mutations in the zona pellucida, that can also lead to the fertilization failures or spontaneous conceptions. But a simple answer to is yes, we can go for the ICSI and achieve the fertilization. But what we generally see in the lab is things like this, where we have a thick zona pellucida, a dark zona pellucida, or a septate one. So as per this study, what this says is, just a minute. So as per the study, what they say is the oocyte having a thinner zona pellucida with a mean of around 16.6 micrometer exhibit a higher fertilization rate, right? As compared to those which have a thick zona pellucida. So recently, the studies from the Polscope says that if you look at the zona pellucida, there are multiple layers, but if you have a thick inner layer, that is around 10 to 12 nanometer in thickness, it gives a better pregnancy rate and a better outcome. This is again confirmed by the birefringence studies done by lots of people. Even Dr. Ramaraju from India has also worked on it. Montag has also worked on it. If you hire birefringence on the inner layer of the zona pellucida, it's going to give you better results and give you better live birth rates. There are always a question in the lab when we go that there is a dark zona pellucida. Is it going to be Is it going to impact the development of the embryo? Is it going to impact the hatching? Do we need to use the laser for it? The answer is no. It is not going to impact at any point. The outcome is same. There is no impact on the embryo development and the hatching or the implantation of the embryo. Although there are a few abnormalities on the zona which have been seen, like the jagged zona pellucida. This is a study which tried to see these specific kind of zona pellucida, and they find out that if you have these abnormal kind of zona pellucida, you come to a pregnancy rate of just 3.6%. When you compare to a pregnancy, when you compare to a zona pellucida, which is absolutely normal, around 26.6%. So try to rule out these kind of oocytes when you have in your practice. And especially these kind of septate zona, these are also in the form of put in the bucket of the abnormal oocytes, especially by the grading system by the ASB. What we follow is the Istanbul consensus, but there is also Spanish guidelines, which is much elaborated and more discussed. And they have, except from taking the cell numbers, fragmentation, symmetry, multinucleation, they have also taken care of the zona pellucida. And they say that if the zona pellucida, which is abnormal like jagged or they have septate, it should be considered B grade and not A, if the embryo is even A grade. So this is the comparison of all these studies and all types of zona pellucidas by the Safed Osbook. If you have a thin zona pellucida, it is going to increase the fertilization. If you have a thick zona pellucida, it is going to increase the oocyte development. Embryo quality is increased. If you have a high birefringence, the high mitotic spindle visualization is there, high fertilization rate is there, increased embryo quality is there, increased blastocyst formation is there, increased implantation is there, increased pregnancy is there, and even an increased live birth rate is there. So if you have a low birefringence, there is an increased miscarriage data. Now moving to the parivitelline space. So the parivitelline space is nothing but the space left by the zona pellucida outside of the oolemma. That is it. It contains the polar body, which is the haploid set of the chromosome, excluded by the oocyte. and sometimes it contains the debris, which we sometimes see in our practice. So what generally been seen is if there is a higher paravitline space that is somewhere associated with the aging of the oocyte. So if there is a higher paravitline space, that means it is associated with the somewhere the aging of the oocyte, because the oocyte cytoplasm shrinking somewhere and going under the aging. There are also reports regarding the granularity of the paravitline space, that if there is a higher doses of the HMG, especially, there are higher granularity and it's going to impact the development of the embryos. Like these kind of granularities. So if you have a granularity in the paravitline space, that may impact and you may have poor embryo. This is why I'm saying I recently underwent a patient where I have seen this kind of debris. As you can see, there are lots of debris. See? Lots of debris. When I'm injecting the sperm, even I was not able to see the polar body. There were 12 oocytes and all of them were like this. Although I was able to fertilize them. So you can see they used to look like this on the upper left-hand side, but this is a picture of the day 3 embryos. They were lagging. So I froze them on day 4 and they were on 6 and 8 cells. And I'm still waiting for the result. I've thawed them and transferred them. So this is the conclusion by this Safet, which says that if you have a large large paravitline space, there is a reduced fertilization rate, reduced embryo quality. But the other study by 10 says that it is increased embryo quality. The presence of granularity, the other says that the oocyte maturity increases, but the implantation rate and the pregnancy rate decreases if you have a granularity in the paravitline space. Now the polar body. So there are different type of polar body. Like if you normal single polar body, what we always want is sometimes you see a multiple polar body, sometimes you see a enlarged polar bodies. So polar body is basically a set of haploid chromosomes. So there are methods like some people even select the oocyte on the basis of on the basis of genetics of the polar body, also by taking both polar body and looking under the genetic analysis. And you can actually rule out the abnormal polar bodies and you can select the normal oocyte. And then again, you have the different type of degenerative polar bodies and you can come to it. According to Abner, he says that if the polar body, even it is degenerating from 1 to 2 to 3 to 4 different type of polar bodies. Like if one is the ovoid first polar body with smooth surface, second is the ovoid polar body with a rough surface, third is the fragmented polar body, and fourth is the huge polar body. He says that there is a decrease in the pregnancy rate and the outcome is poor. But the more data which is coming out, and in 2006 some paper came out and they also compared about the polar body first, second, third, and fourth and 5. They found that there was no difference if the polar body is round, rough, or degenerated. It is not going to impact the outcome. But the most important thing is it should not be large and it should not be mature, means too small. So this is a picture of a multiple polar body. So the issue is here with the multiple polar body is when the polar body goes out of the cytoplasm, it takes out, single polar body takes out this haploid set of the chromosome, right? But when multiple are there are chances that the other polar body might have taken the other chromosomes along. So these kind of oocyte basically are leading into aneuploidy. And then with that, with the chromosomes also, the oocyte is losing the cytoplasm. Losing cytoplasm means losing your ATP contents and a poor potential for developing into a blastocyst. So this is a conclusion by a Safet that if you have an intact polar body, definitely the fertilization, embryo quality, the blastocyst rate, the outcome, everything is nice. And if you have a well-shaped morphology, everything is nice. If you have intact and well-shaped morphology, everything looks nice. But you have a degenerated, the fertilization rate is less. And if you have a large polar body, the viability is reduced, the fertilization rate is reduced, and the cleavage rate is reduced. At the end, you have a poor outcome with the large polar body and multiple polar bodies. So this is a conclusion by the Alessandro, which I was talking about, the main paper. Does the morphological assessment predict the oocyte development competence? And a systemic review proposed. Basically, he come to a oocyte literature score, and he has given a score to all the parameters which is available. That is whether it is relevant or not. So that's why I was saying initially that whatever has been given to me is actually injustice, because zona pellucida, paraventline space, polar body, they don't have much value to give. The score is very less at the end. If you look at the studies which says that it has a positive correlation, no correlation, or negative correlation, there are hardly good quality of studies which actually talks about it. Although if you look into the cytoplasmic factors like the vacuolization, the granularity, and ACR, they are more component factors to talk about the oocyte quality. Although for me, if I have to talk, yes, the septate zona, the jagged zona, the enlarged polar body, and if there are debris in the paraventline space, these are few things which might impact the blastulation and the outcome for the psyche. Thank you.
Dr. Rahul?
Rahul is on my stage. We both are ill.
Well,
yeah, I completely agree, Gaurav. It was a wonderful presentation. But Sanket bhai, if you can continue the moderation, yes.
no problem. Yeah. Firstly, congratulations, Gaurav, for that excellent presentation. You covered, I think, almost all the points, but I would like to ask you something about called discoloration, right? With respect to like a large PVS, you also get a debris in PVS, which you showed a beautiful XC video where you saw a lot of debris in the PVS. So what could be the possible reason for the origin of these debris in the PVS?
There are few studies, Sanket, which says that there is, if you put higher dose of gonadotropins, the oocyte tend to release some factors which increases in the paraventline space. The other studies also there which says that there are chances that the polar bodies actually disintegrate in the paraventline space into multiple forms, and they look like the precipitates. So there is always a confusion. But what I have seen in my case, all oocytes were like that. So it is basic. And I asked the clinician also.
But polar body wise, you can make it out, right? By looking at the color. Mostly the debris will be dark in color. Most of the times, if you look at it, they'll be like when compared to polar bodies, they're very much dark in color. So if you can exclude them, not considering as polar bodies. With respect to your last slide, where you showed a oocyte literature survey score. So there you concluded saying that there is no correlation, positive correlation with respect to extracellular species. But if you look at their own data, there is a positive correlation with ZP as well as polar body, which is not seen in cytoplasmic features.
Which one? Sorry?
No,
the ZP.
ZP as well as polar body, it is showing a positive correlation with outcomes. And you don't see positive correlation with cytoplasmic
slightly
features.
Positive. If we have to go, have to go more than 7. If I look at the picture, I have to go at more than 7, which is more predictive. If they are dark, more than 7 ones, they are more dark. So,
but if you look at the fun part of the study, I don't know, there is no positive correlation at all with respect to cytoplasmic features. It is only polar body and ZP are showing positive. If you just go back to the slide, if you can.
Sure, I can.
And I think it's a very recent paper, I think.
It's a recent one.
Yeah, just see the image. Positive correlations, if you look at it, the value of -1, it is zona ZP and PB, right? And you don't see that positive correlations with the refractal bodies, granularity, color variation, and other parts of cytoplasmic features. And also with respect to the number of studies which analyzed is almost same with respect to all, but the negative with no correlation is almost same in both of them.
Yeah.
I found that very interesting because in spite of that, I don't know why they got the oocyte literature score, right? Yeah, which is very less with respect to extra cytoplasmic with compared to cytoplasmic features. Yeah, any other questions?
Although I find it a very beautiful study to present, because see, when I was reading in iHERA, the atlas, I used to read nothing is important. Even granularity is not important. This is not important. That is not important. But when I look at if I have to give a conclude answer, then I found this study is giving me some idea that this particular thing, 2 or 3 things are more important than the other things.
Yeah.
If I can jump in, hi Gaurav, nice presentation over there. Yeah, on a lighter note, what Sanket Bhai is trying to say is we have not done injustice to you. We have given you something which is equally important, first of all.
You got it.
And you have got an important one. And one more thing is, like you said about the study, that this is not important, that is important. Yes. That's a point to stress over there, that there's nothing absolute. What probably all these studies indicate to us is there's not an absolute single feature which can show you that this is bad or not, given certain exceptions, like your polar body is present or not, might be a giant polar body, and someone might be like SCR. And these papers, I think Thomas Ebner had put up where he said almost 40 to 50% of the oocytes will at least have one of the abnormalities.
I agree with you.
And so that means there's something much more going on, much more complicated than absolute yes or no. I think that's the gist of these studies.
I agree. Akash, I presented a paper way back in 2011 where I put the B-grade embryos in one patient. So sometimes we have B-grade embryos, right? The number is less.
Yes.
Those compared with the A-grade embryos we report. So even those B-grade embryos have a live birth rate of around 8%.
Yes.
So we cannot deny that, yes,
so
even
it
can also give you a good blastulation in the pregnancy rate. We don't know it.
Grading is arbitrary. Grading is done by humans, not by nature. So that's where the arbitrariness comes in.
Right.
Yes. Let us not get into more details because we have a panel discussion which is lined up. So we'll discuss in detail in the panel discussion. So thank you so much, Gaurav.
Thank you so much. Thank you, iHERA. Thank you.
Thank you so much, Dr. Rahul, and thank you so much, Dr. Gaurav. So without much further delay, we'd like to start the panel discussion. Can we have the CVs, please? CVs of the panel.
Yeah, sure, sir. Sure. Sharing.
So I have Dr. Akash with me as a co-moderator for me for today's panel discussion. And we are very esteemed panelists with us. And of course, none of them need an introduction. Can we jump to the panelist?
Yeah.
Yeah, first we have Dr. Manisha Vajpayee, a dear friend of mine who is currently working as a director at Scientific Research and Embryology Department of Clinical Embryology and Molecular Biology, Pacific Medical College, Pacific Medical University, Udaipur. And welcome, Dr. Manisha. And next we have Mr. Balakumar N.P., who was a SRM certified embryologist and is currently working as Chief Embryologist at SRM Institute of Medical Sciences, Chennai. And welcome, Dr. Bala. Next, we have, again, dear friend of mine, Hemant Kumar, who is currently working as Scientific Director and Chief Embryologist at Genia Fertility Center, Bangalore. And he has 12 years of experience as a clinical embryologist. Welcome, Hemant.
Thank you, Sanket.
Yeah, next we have Nancy Sharma. She is a Chief Embryologist and Lab Manager at the Department of Reproductive Medicine. And she is an ASRM certified embryologist and also certified from ASRM in fertility preservation for reproductive health providers. Welcome, Nancy. Next, we have, of course, Ved sir and Sanjay sir. I think already introduction has been over. So I would like to invite you all for this wonderful and interesting panel. So now, Dr. Akash.
Yeah.
Start, please. Yeah, I'll just share the screen.
Yeah, please. So thank you, iHERA. Thank you, Ved sir. Thank you, Sanket Bhai, for making me a part and giving me a chance to moderate this session. And we have a wonderful panel. Hope it would be quite interesting for all of you. We had a discussion about the extracytoplasmic features, the cytoplasmic features, the metaphase plate, and how it is important. We probably all of us know what is important to a large extent, what is proven. So we'll be taking you through our slides and just a slight warm-up based on what we have already got. We know that we were just discussing some time back that how the embryo grading, what we do is not all informative over there in terms of the pregnancy potential and the live birth potential. Similarly, when we say the quality of the embryo, we tend to associate it with the morphological grading, what we are giving over there. And what impacts the embryo quality as such majorly is your gamete quality. Yes, it includes your stimulation and other parts as well as your lab conditions, the experience. There are so many variables agreed, but majorly we can say if there's one thing what we put up, what is responsible for the pregnancy as such, it's probably the female gamete. The question, like we had seen previously, the moment OP is over, clinician comes in and asks two questions. We get probably kaise hai, kitne hai. These are the two questions that we commonly get. How many you have got and how do they look like? So probably your oocyte quality is not only what we look at. It's not just the nuclear and the mitochondrial genome, which we have seen how it can affect the competence of the oocyte and the developing embryo as well. But probably it's much more of a complex interplay which is going on in the development of the oocyte. A oocyte, which is formed probably 23 years back during the fetal period, and it is lying dormant over there, and it becomes active. Few of them become active, developing by the microenvironment, which is provided by the ovary, the pre-ovulatory follicle. There's lots of transcription going on, translation going on, lots of organelle changes which go on, and these translate into the cytoplasmic maturity, which we assume we know of seeing under the light microscope. So the elusive search always starts with the arrival of the very first follicular tube which comes into the embryology lab. Scan for it, scan for OCCs are there or not, that frantic search, kam se kam ek to mil jaye, let it not be without anything, without any OCCs. And helping us in this, what we have seen already, that there's a ASHRAE which has classified in terms of your extra and intracytoplasmic dysmorphisms, and your extracytoplasmic dysmorphisms in terms of first polar body morphology, your PVS, your discolorations, your ZP, your shape anomalies which could be there, and they are the refractile bodies, the central granulation, vacuolations, and SCR as have already been discussed. So with these warm-up stories, we would like to take further some things which we probably tend to overlook, or probably we tend to not give that much importance in the lab.
Yeah, what we thought of doing it is like breaking the norms, like routine. We post a question and we show a lot of data according to, which is related to that. So we thought we'll have a little different kind of discussion. And there are a lot of arrows which are like around 8 to 10 arrows with us, which we'll be shooting on the panelists. And I think they're all well equipped with a shield and to bounce back with their answers with respect to this topic. Yeah.
And these arrows are not meant to hurt anyone. This is just to guide them where the persons have to look into. So going with the first arrow, how does the stimulation affect the oocyte? Just now I was saying about it affects your oocyte is affected to a lot of extent of where it develops for stays for major time of it. So what experiences we have in terms of how the stimulation is going to affect the oocyte quality? So we can start the panel. Anyone can take the question, please.
I'll take the question now.
Yes, Emma, please.
Just, we all know that there is no control over stimulation that is it is compromise the oocyte quality in the various aspects. We look at the stimulation protocol where the standard protocol, it will take 10 to stimulation protocol, it will take to 10 to 12 days, and gradually the size of the follicle is 1.72 mm in each day. It has to develop. That is the normal ideal way. In some of the cases, we're in the unknown phenomena. The stimulation is going behind and using of more HMG. In those cases, the oocyte quality is going to compromise. Where exactly in the large perivitellin spaces, maybe in those cases the stimulation could be behind the days. And as discussed in the previous session, a lot of debris is present in the PVS because of the patient is not response properly. In those cases, maybe administration of more drugs that can causes HMG as well as more drugs causes the increase the perivitellin space as well as the debris we can see in the perivitellin space. And where in the stimulation starts in the protocol, estradiol levels, which is not correlating the follicular number, that also compromises the oocyte quality.
Okay, so we have seen the duration of the stimulation, the dose of the stimulation. So anything to do with the protocol that is followed say your antag versus agonist, or the dose, which type of FSH is used, RFSH is used, or whether you use highly purified FSH. So any differences you have seen? I mean, I don't want the ones which are there in the paper. Yes, there are many papers which say, but anything which you have seen personally, any differences in such?
Yeah, compared to this one, now it is all short protocol is more well established compared to the agonist. Antagonist is most commonly used now, and clinically and gene level, you look at that it is suppress the what exactly the point?
Maturity.
Maturity as well. Maturity as well as the quality. The granulation, it is a part of control over stimulation. It is a part of stimulation protocol. But when in the long and agonist protocol, where we see increase the perimeter spaces more of the time, which causes the post maturation oocyte, where the cytoplasmic will be shrunken compared to this one. So now it is easily available. Antagonist protocol, it is always good and more effective.
Or even that there are so many ways of doing the stimulation, but I think we should individualize the protocols. So according to the poor responder or high responder, these kind of patient have different kind of should have different kind of protocol. So then it will be better to get the oocyte quality will be better, because there are so many patients of endometriosis and other kind of abnormalities are there. So in these cases, definitely you will get bad oocyte quality. So at that time, you have to, whenever you start stimulation protocol, you have to take these points under consideration, that what kind of patient is there. And according to that, we have to follow the stimulation to get the better quality of oocyte.
And also the history of the patient and in embryonic status, I'm telling, history of this embryonic status and all, the clinicians can plan the stimulation protocol so that we can reduce the risk of getting any abnormalities in the oocyte. So, because now we are not sticking in the same protocol for all the patients, we are having a different protocols for the different profiles. So we can we have to plan this cycle, it depends on their history of embryonic status also.
Yeah. So the gist of what we could get is it has to be tailor-made, probably personalized, individualized protocol. And Charu sir, yes, I see Charu sir's hand being raised. I was coming to her.
Yeah, I would just like to add here this stimulation protocol decision. The very important part plays is by the endocrinology lab, because our all this assumption and stimulation strategy depends on the endocrine levels of the hormones. So I feel that before stimulation, we should have to stick to quality in endocrine evaluation of the patient. What are the values of the hormones, and then accordingly, that may be one of the deciding factor which stimulation protocol that patient needs.
And, yes, it is everything like already said by sir. You have to sit in the endocrine parameters as well, because your decisions are going to be based on that. And if the data what you are going to make your decisions on is wrong, then obviously your stimulation may get compromised.
Yeah, because I have very commonly seen this, that E2 values never correlate with the what is finding seen under ultrasound, and what you are seeing, it's always different. So that is what I feel, that the endocrine function and endocrine testing should be given that much importance before starting with the stimulation protocol or selecting a protocol.
Here I would like to add one more thing. Not only the endocrine profile, sometimes actually it happens because different labs will give us a different kind of values for the same patient. But before starting a stimulation, the basic antral follicle count can also means these small things can make a huge difference. That is a good sonography on day 2 and basic antral follicle count also have an impact, because we get hormonal variations at times. So these things are That is the only thing I would like to add to this. Sometimes AMH is also not matching, but AFC can give us a clear-cut idea. Okay, what we
So it's like rely more on what you see directly rather than depend on something else. So rely more, not totally. It's more, rely more on what you see directly. Right? And it's AFC in combination with the AMH, which are the best indicators as of now, which are the present indicators. Personalized protocol. Get your lab which is standardized. I think keep it at one lab.
AMH is again a topic of debate because it's not a very true indicator of result. So we'll not.
That's why. But I think
we'll not get into those details. I think that's why combination.
Recently, there is one paper who shows that AFC and AMH both are
combined together.
Yes, that's what I would. That's what I was saying. Precisely the same thing.
Yes. So one last point before we move on to the other question. Probably it's a stimulation protocol also play definitely some role in our treatments getting better. And that's why we are seeing our pregnancy rates getting better. So it all starts from there, not once it enters inside the lab, but rather from there, the patient selection and the stimulations, all of them. Yeah. Can we move on to the next question?
Yeah, coming to the arrow number 2, well, what is the most important factor in oocyte quality other than the nuclear maturity? So we tend to incubate the oocytes once the OPU is over. We normally incubate the oocytes before the IVF or ICSI, whatever. So what could be the reason for that, and what is the another most important factor apart from the nuclear maturity? Anyone can take up the question.
Yeah, as we all got so many information about cytoplasmic and extracytoplasmic parameters. So other than nuclear maturity, we'll be very focusing on this cytoplasmic and extracytoplasmic parameters to assess the oocyte. And also the speakers have mentioned about the parameters of extracytoplasmic parameters, which is correlating with the oocyte quality and also the progression of the oocyte and the embryonic status. So we'll be concentrating on the both parameters other than nuclear maturity.
Okay. Yes, sir.
That that nuclear other than nuclear maturity, there is so many factors we can say about that. There is already 2 speakers told about so many things to us that Jonah and that polar body and everything.
Sir, I knew this. So I knew this.
All the intracytoplasmic and extracytoplasmic.
I knew this, that the speakers are going to cover this very topic. So I intentionally, deliberately, I put most important factor apart from nuclear maturity, so that we can streamline to one particular factor.
What each one of you has found in your personal experience. That's this more to do with that.
Then polar body.
Polar body, yes, sir.
Cytoplasm is very important.
Cytoplasm is so broad term, I would say.
Actually, so granulation, whether it is a central granulation or easy equally distributed homologous cytoplasm, means everything is important. How can you rule out?
Yeah.
It is very
for telling you that polar body
actually.
No, Manisha ji, what happens is, what we would like to get the answer is with respect to what do you consider the most important factor apart from that? Yes, you know that everything is important.
Yeah.
Apart from nuclear maturity, what do you think the next most important factor that has to be considered with respect to the maturity? So yes, as I said, yes, everything is important, but which is the most important factor apart from the nuclear maturity is what
from my point, I can say, see, when we are having granularity or discoloration of the cytoplasm or vacuoles or anything in the cytoplasm, at least we can show them and we can explain there is something is there. We can call it as abnormality. And from my point, I can say the perivitelian space is the biggest thing that we can't handle and deal with it, because we can't say just like that, doctor, we got all oocytes are large perivitelian space, so that we had a poor fertilization. That is the thing. So, but that is the factor. Papers are showing results in Like there is a correlation between perivitellin space with the low fertilization and the grade 3 embryos and all. But that is I think from my point, perivitellin space is a big deal for us.
Great. I think Sanjay sir is with us. Sanjay sir?
Yes.
So please.
So, actually, I'm driving, so I'm not sure whether I would be able to focus on my answer or not. But one thing which I would like to convey is that all these features we are observing when we are denuding the oocytes. That means we intend to inject the sperm, and it is not meant for the regular IVF insemination.
Right, sir.
So now there is a hell of difference between a regular insemination and the oocyte quality that we observe before ICSI. You hardly see many abnormalities on day one of your regular insemination. So this gives me an idea, a suspicion that most of the abnormalities, not most of the abnormalities, but at least few of the abnormalities are actually created by us and artifacts of the handling before we inject the sperm. For example, the shape of the oocyte. So you say the ovoid is not good, or the fractured zona is not good, or the the septate zona is not good. Sometimes these may be because we have handled the oocyte maybe in an inappropriate way, or the oocyte was not tolerant to those stress. So that is one point. And another thing is, which apart from the cytoplasmic maturity, during ICSI what we observe is, first thing is the elasticity of ulemma.
Yeah.
So the elasticity of ulemma and then subsequent cytoskeletal strength of the oocyte. So if you see an ulemma which is very elastic, you are not able to pierce it through, or it is too less elastic that you can just pierce it without any resistance. So both the cases, the oocyte quality is not good, in my opinion. And if the microtubules are not well formed, again, the oocyte is going to collapse and it will degenerate.
Yes, one last point, Sanket.
Yes,
The question frame is, I like the question framing. What is the most important factor other than the nuclear maturity? On lighter note, for embryologist, the nuclear maturity is very important.
Yeah.
Because nuclear maturity is where, it is not, when you see the more immature oocytes, then the question will arise and RO will come to you, your denudation of the time, incubation of the time, and ultimately the questions arises for the skills of an embryologist. So nuclear maturity is very much important as per concern the oocyte assessment. Apart from that, as I strongly agree with Sanjay sir, which is elasticity of the ulemma when you're doing the ICSI, what we learn, the form the funnel shape towards the center, that just shows the cytoplasmic maturation, how big funnel it is forming, how less funnel is. Depending upon that, we came to know that what the oocyte cytoplasmic maturation of this particular oocyte. It may be different from each individual oocyte, but apart from that, I strongly agree that ulemma elasticity, it is very much important.
Yes, sir. Yes, Simon, rightly said. Yeah. Yes. To conclude the question, yes. First, starting with Dr. Manisha, yes, she rightly mentioned that everything is important apart from the nuclear maturity, including all the cytoplasmic features as well as extra cytoplasmic features. Along with that, I also agree with what Bala said. Yes, it's PVS also is more important, and also Ved sir mentioned about polar body. That is also very important, which we cannot ignore. The very fact that the morphology of the polar body and the outcomes. And similarly, what I strongly agree with Sanjay sir also. Yes, most of the things, since we denude the oocyte on the day of OPU and we get to see a lot of things, and we have created it. So we don't know exactly what happens with respect to in vivo oocytes as well as those oocytes which are kept for IVF insemination. Maybe this is like maybe most of the things which have there is no straight away correlation with the outcomes, but still and finally the Ulam elasticity is one of the most important factor which we don't get to see by morphology. We get to see only by doing ICSI. So which is extension of the extension factor apart from the nuclear maturity. So having said that, yes, it was wonderful to all of you that you gave a lot of inputs and a lot of new things that have come up. So I would like to proceed to the next question. Yeah, Dr. Akash, you're taking this question? Yeah.
Yeah. So are we on the same page? Like, still morphological grading is the gold standard. We have seen the 2 talks and the first 2 questions about the morphology and stimulation protocol. So is conventional morphological grading still the gold standard as far as oocyte quality is concerned, or we have any difference of opinion over here?
I think Nancy is sitting quite for some time. We can shoot.
Nancy can.
For now it is that we are stuck and confined with the subjective morphological evaluations and morphological and the maturity of morphological evaluation and the majority of the oocyte. To that, I want to just add, yes, I am going with the gold standards, which is the morphological grading for first, because I can see that in the very first day on the lab, that what is the morphology of the oocyte and is it mature or not. But yes, other factors are also there, like the biomarkers, but we are not going to see them. We are going to only see the mature morphology of the...
You mean to say, Nancy, that you're doing straight away all ICSI, no IVF, right?
Yeah, no, I am doing all. I'm also doing IVF, but in a few cases we have follow ICSI. We follow ICSI for most of the cases. Yes, the morphological grading is still the gold standard. And see, if I talk about the COC grading also, if I'm doing the binary system of the COC grading, I'm not going to lose anything to that. I will add that if I see a compacted COC, I mean, I'm not sure it is immature or mature. After denudation, I can know that if it is mature or not. And if I'm doing IVF to that, I'm anyways going to put it in the IVF for examination and going to say it the very next day. I'm not going to throw it. I'm not going to discard it. It's going to be used. So yes, the morphological grading for sure.
Yeah. So I just want to ask as a sub question for this. So is anyone following an individual oocyte for this? When you are grading them, are you grading them as a cohort together, or are you grading them individually and following them till say day 5 or say till transfer as well? Nancy?
So we do both, because when a cohort is, all the cohort is affected by something like the perivitline space is abnormal or something which is abnormal in all the oocytes, we mark that, we note that. And if we see something very unusually abnormal, that is SERs. If I see SER, I would definitely want to tag it to that particular oocyte, that yes, we saw 3 or 4 oocytes with SER, and this is the grading of it. This is how they are going to develop further, and what is the final outcome out of it. So we do both for that.
So anyone following, I wanted to ask, like, on a regular basis for each individual oocyte, this is the oocyte which was there.
Actually, we are not considering separate oocytes that we are doing ICSI, but as Dr. Nancy said, we'll see the cohort of the oocytes. But when we are seeing any abnormality, that specific oocyte will be cultured separate and will be monitoring. And also that procedures will be followed like separate only, like freezing or anything that we will write a comment on this particular oocyte as this comment. Like that we do. And the question like conventional morphological grading, that is actually a gold standard method, because all embryologists will face this after immediate oocyte screening. That clinician, our doctor will come and ask, how was the cumulus? They'll ask how many number oocytes we got and how it is. And immediately they will ask, is it expanded? It is like look like M2 or what? So obviously that morphological grading should start from that point. So it will be a gold standard method only.
Right. So
not to learn any other morphological, apart from morphological grading, any other way of grading the oocytes?
No.
No, because all other methods are invasive. You can't, we can't use them in embryology lab. If you are talking about gene expression studies on all those things, they are definitely more conclusive. But unfortunately, or fortunately, we can't use them. In our lab, we have to stuck to the morphological gradings. Recently, I have shifted to individual like grading of the oocytes and individual single droplet culture, and probably that I'm finding it more conclusive. Actually, at times we got to see oocytes which are looking quite bad. I've graded them badly, but I got good blastocysts out of them, and those things are quite surprising, and they are the main points where we are stuck. Why it is happening? So. Individual culturing or individual grading is really, really helpful if you can justify with your workload. As Dr. Akash.
We are doing individualized grading in our system, but culturing all together, not separate. But if we find any specific thing, so definitely I culture them in other drop, not in single drop, like what we are doing.
Anybody has the experience with? Since now a lot of AI things are coming up with respect to selection of the embryos. Similarly, is there anything called as AI-based tool to select the best oocyte? Of course, again, it is dependent on the morphology itself. But this is just add on to the regular conventional morphological grading what we do under the microscope. This is something different from that, right? So anybody is using AI-based tools to? Is there any? First of all, is there any tool? And if it's so, anybody is using it?
Tool is there. There is one company, I think that I forgot the name that company, but they are actually recently published data on that also, but we are not using that.
What is it? So it is based on the morphology.
AI.
Yeah, based on the picture, it is going to select the score.
Yeah.
Okay.
Yes, the robotics team from Bangalore, they are actually making a tool for this thing, artificial intelligence. They're working on elasticity of the membrane, ULM membrane, and usually now they succeed in RoboXC called how to hold the oocyte, which is a minimum pressure. How we use in the general when doing XC using the
a lot of pressure. Yes,
it will select. It will select by their size also. Size of the oocyte also.
In those things, yes, AI is, in the field, it is. We all know that it is our next future to know artificial intelligence. It is a tool. It will give in one picture. It will give everything. The oocyte in the molecular level, everything. Now
that is again a debate, because how much you rely on AI. This is again a topic of next discussion, because I don't believe at this stage it's simply a data generated by a computer which is relying on the images given by us. It can't be sufficient enough. As
I don't know about the genetics.
I would say there would be a lot of companies which would be really unhappy with what you're saying, and the world is going towards the direction of AI. And probably it is very, very nascent stage right now to say how AI works.
We don't know the markers which we are putting into the AI system. We don't know what are the robust markers we are going to give them, and how can we rely on those results unless we are not very sure. That is the question.
Probably that is the role of AI is. That's where it comes, something which is beyond human capability, something beyond which humans can see. Like I said, it's still an open question. How much it will be. But I think that is one of the steps in which probably the science is progressing ahead. And one of the tools where you remove the subjectivity of your grading, where we have been continuously talking in so many webinars over the subjectivity of the grading, say, of the embryo or the sperm or the oocyte for that sake. Probably AI may help a bit to make a level playing field.
Let's see.
Time has to answer.
Let's see.
Now, we cannot answer the question, but in the future, it could be, we don't know, because it looks very promising, because it is not a invasive technique as such. So you're just taking the pictures and just looking at the morphology. You're getting probability that what this could be, because this is again based on the lot of data that has been fed, like machine learning has been happened. Based on those algorithms, these are going to predict the score. So probably yes, if it is effective, why not? So that will be a thing. And any other substandard premium standards apart from morphological grading?
I think the final gist of the answer is yes, morphological grading is the gold standard which is available right now. Others are still in the development phase and the research phase still, which time will say as such. And fortunately or unfortunately, we are stuck with it. So, you don't have a definitive answer for everyone, whether it's good, bad, or ugly, or it's really good. So we still don't know.
And I think as of now, the definitive answer is morphological grading.
Yes. Yeah. Yeah. Can we move to the next question? Yes. Yeah.
Akash, please take the question.
Sure. Yeah. So what Nancy was saying sometime back. So I want to know from individually, do you do on a regular basis OCC assessment in your lab, and to what extent do you use it based on the grading? Do you make any decisions based on that actively or anything? So we'll start with Nancy for that case.
So I have already answered this in the previous question that we do not do the regular assessment of OCC, but definitely if we have something, I see the binary scoring system, we don't do it. But yes, if I see something which is compacted, I'm going to use it anyways. If I'm going for ICSI, I'm going to dilute it and then see if it is mature or not. It could be mature, it could not be mature. And if I'm going for IVF, definitely keeping it for the examination. So yes, I'm doing it. I'm not doing it.
We'll come back to that part. Dr. Manisha.
As per a routine protocol, we are jotting down the OCC compaction level if it is well radiated and it's fluffy. So it gives a kind of concern. Okay, we are expecting a good result, but we may get surprises even in IVF lab. So fine, but we are actually mentioning it. But I have seen it is not creating much impact because at times, as Nancy have already has told us, that even compacted OCC has given us a good M2 oocyte, which turned out to be a good blastocyst. So I can't say that there is a direct correlation or we can relate it, but yes, it as a habit, because since IVF days, we are trained to see the OCC maturation, radiation, fluffiness. So it has become a habit and we are mentioning it.
Wait, sir.
So as a routine, I'm not doing this is OCC assessment. But of course, if I see something different thing, dark kind of cumulus cells or different kind of things, definitely I'll check it. Or nowadays we are doing more of ICSI, so anyway we have to denude everything. So it is like that.
So coming to that part, like we are going more towards ICSI. So I have my co-moderator who does most of the cases IVF wherever possible. So would it influence a decision change anytime for any one of you if you see OCCs which look quite compacted and not expanded at all? So would it make any change in your decision?
For some time, I think.
Yes. If most of the OCCs are compacted, I'll go for IVF. Go for ICSI. I'm sorry. Definitely.
You go for ICSI or IVF? Compacted, not expanded.
Not expanded, I'll definitely go for ICSI. I'll denude it and I'll do ICSI. Because I come to know what is the problem with the oocyte. We can't leave it like that. Okay, it will be fertilized or not. So, okay, fertilization, we have tried that. We have crossed that level. I'll do the ICSI.
Okay. Hemant and Bala, can we have your views?
Yeah, actually, we have a practice of assessing OCC because though we are not doing much IVF cases here and we are not taking as a predictive measurement, depends on the OCC, we are not deciding any protocol like IVF or ICSI, but still we will be getting to know how to at least from the basics. If I want to say, we just come to know the how to use the denudation, how we give pressure and all. Because with the if I am okay with this cumulus and well expanded and it's good, so I can be not worried to be I'll be okay with that. Oocyte will be M2 or something will be good. So obviously, and then we have a practice of seeing the history of patient and also the embryonic status and oocytes of history of patient, so that we'll be correlating with the previous cycle if the patient had, so that we will be assessing the OCC.
Okay, Hemant.
Yes, I do follow the assessment of OCC in my daily practice because this is how when clinicians is always before the OPU, she will tell this much is a dominant follicles and this much is a intermediate follicle. In those cases, I do and I'll teach my colleagues as well how the expansion is and how to know whether when you choose the technique like if you want to do ICSI or if you do IVF. Definitely, you should know the OCC grading. That is a must for embryologist. It is a basic education to choose the technique whether you want to do ICSI or IVF. Most of the time, yes, which is very distinct. And a previous patient having having a lower fertilization rate or embryo development is not so great. We know in those cases we're not going to take a chance. We'll go for ICSI, but it is cases tied. In those cases, to choosing IVF, we look at the OCC, and depending upon that, we'll see what is the time of incubation we need to do. It is coronary rate is very well distinctive or it is very compacted. Those decisions definitely will change the science will definitely change the decision.
Yeah, Shukla sir, yes.
So
yes, sir.
I have been practicing regular insemination ever since I learned how to do it, and I still prefer to do it. Of course, there are certain professional challenges and pressures, but still, in my previous lab where I was a full-timer, so I had this habit to record each and every oocyte. So at that time, because we had certain criteria, if we are addressing a non-male factor couple, and if it is their first cycle, we would prefer to go for regular insemination IVF. So in that case, whether the OCC is looking little compact or not so fluffy or cloudy, still we would go for a regular insemination. And to my junior colleagues who are not in tune with the regular insemination IVF, you still get 70% fertilization. Okay. So it's very thin line, but still maybe because you have an increased workload and you don't have all those things. So there's no harm. And in fact, now it has become a law that you should have a witness. So why not have another colleague in your lab and just ask? Because I have seen this in many overseas countries where the chief embryologist used to dictate the distinct features of the oocyte and the junior gets it noted down.
So I think the gist is we have a divided panel in terms of 3:3, some do, some don't do. But at the end of the day, noting may make no harm as such. And it may help in certain cases in deciding your denudation times. You can postpone that because there's a biological variability with how each of the patient responds to this. And not all OCCs might be equal. So your denudation times can be postponed, preponed, or could be on time based on how mature they look based on the expansion. Little tiny changes which you can make and probably which can help you decide better sometimes. IVF versus ICSI may be helpful in some cases, definitely not harmful at all. And this was the last question, like, are we seeing any changes in terms of the OCC expansion? Earlier we used to see agonist cycles, this nice fluffy looking cloudy translucent kind of OCCs, which probably with the advent of the antagonist cycle, which we are not looking at that much expanded ones, that fluffy kind. So is it just something which we have seen as moderators, or others feel the same, the expansion of the OCCs, of the mature oocytes?
I think I haven't seen this kind of thing.
Much expansion, like what we used to see, totally translucent, where, with naked eye, you could make it out something is mature looking. without under
But
the
definitely
microscope.
when we give trigger of antac, in these cycle, definitely I saw some difference that the tubular cells are compact kind of, and sometimes it is dark. On trigger of like just decapeptide trigger, I have seen so many cases like that. So sometime I ask clinician to which trigger you have given. Is it decapeptide? So they say yes, decapeptide. So I don't know, but I have seen this kind of features that it is compact or sometimes it is dark cumulus. I don't
Relatively dark cumulus, but gives mature oocytes as such and good results
mature,
as well.
mature oocytes.
Shukla sir, any views on this?
Can't really comment on this because I haven't seen much difference. But one thing which let me quote yesterday's case where we had only 3 OCCs and they all were looking very little. I mean, there was hardly any cumulus. You can't see cumulus in the entire follicular fluid. So you just can't say that the oocyte might have detached from the main cumulus mass. But there was no cumulus except the little tiny cumulus along with the oocyte. So as usual, my first intuition was that probably we'll get no mature oocyte. But to my surprise, all the 3 were mature. So it's very difficult. And if I had delayed that denudation process based on this, so probably they might have over matured.
Yes.
So it's very difficult. I mean, for that, probably we again need an AI.
Okay, so looks can be deceptive, and don't judge a book by its cover is what we got the point over here. So anyone wants to add anything to this? Any of the panelists?
Okay.
Okay, so I think we can move on to the next question.
Yeah. So the next question, our will be with respect to in vitro maturation. So yeah, we all know that the male part is very rich in with respect to gametes. There are millions, but with respect to the female, even though they're born at the time of birth, there are millions. Eventually, they come down at the time of puberty, and they gradually decrease over the years. So each oocyte is very important for us. The gamete part with respect to the female is more important. So in such scenarios, we have something called as in vitro maturation. So we just want to know about the how are this? What is the competence level of this IVM oocytes? Anyone can take up the question.
You are talking about that aspirating oocyte at the size of 14 or 15, or you're talking about?
We'll come into that later. Rescue as well as standard IVM. First, in general, I'm talking about the standard IVM, standard IVM protocols. What is the competence of those IVM oocytes?
So I have done few IVM cycles in past, but the competence level is not so good in that oocytes. I have done ICSI in those cases, but their fertilization is low and everything is even the blastulation rate was also low in that cases. So I think it is not so good, the quality of oocyte from IVM. Maybe I have done few cases, that's why it is I have seen that.
Okay, so okay. Hemant?
Yeah, I also has a very limited number of cases done so far, only 1 or 2. In those cases, compared to the IVF and IVM, in IVM oocyte, what I found in the limited cases that granulation will be homogeneous. I never see the heterogeneous cytoplasmic in IVM oocytes. That is the one major good findings we do. Because that we need to understand embryology when it is a heterogeneous cytoplasm, the holding of the oocyte and position of the aspiration, that is very important. As per concern in the IVF oocyte, that cytoplasm will be homogeneous. I never seen, because I done so very 2 or 3 cases I done so far. In that cytoplasm homogeneity is very good compared to in the IVF oocyte.
Okay.
Yeah, the paper says that embryological outcome is lower in IVM oocytes. Although by practice, there are some like extension things that when we are doing a normal oocyte screening, we will be in stick-on sometimes, and we will be like screening from the follicular fluid, and we will get the oocytes. But when we are doing IVM oocyte screening and all, the procedure it will itself take time. So the temperature, everything is matters on the, in that criteria. So from my point, and when we are comparing all these things, that clinical, embryonic outcome will be lower in terms of IVM oocytes.
Okay, fine.
I have little different opinion here, Sanket.
Please, sir.
I believe our approach for IVM is still maybe suboptimal, and the way we are improving our media and other things. So there are certain groups, especially in Japan and some Italy, and they have achieved similar embryonic development rate as we do in our routine IVF with IVM. But the way they do IVM is different, and therefore it is absolutely necessary to differentiate between rescue IVM and standard IVM. Rescue IVM, first of all, we need to know that the importance of cumulus is of paramount. The moment we stripped off the cumulus cells, the naked oocytes are very susceptible to any stresses. And what we usually do in rescue IVM is we are dealing with the naked oocytes. So it is not true IVM. The molecular dialogue, the biochemical dialogue between the cumulus cells and the processes from the cumulus cells that pass through the zona and reach up to the ulema and communicate with the oocyte is such a wonderful phenomenon that has developed that you can't match, and rescue IVM is never be compared with the standard IVM. So like in earlier days, what we used to do is prepare our own IVM media using our own gonadotropin supplements and all those things. So that was not perfect thing. Again, priming with the gonadotropins, priming with the HCG before we do IVM. There are several strategies, and now there are certain groups, as I mentioned earlier, they are doing wonderful job with IVM, but it is not reproducible at every lab. So we still need to learn a lot.
Yes, sir. Right. Wonderful, sir. And anybody else? Dr. Manisha, Nancy?
Enough data. We are not doing much of IVM. We are not that successful. As Sanjay sir has said, we need to learn more. Actually, we are in learning phase. So I can't comment on this at this point of time. I don't have enough experience. I'm sorry.
No problem. Nancy? Yeah, you're on mute.
I'm saying I have not seen any case of IVM till date. Maybe I'm the least experienced here. Yeah, I believe that what I have read, the standard IVM is definitely a step ahead than the rescue IVM. And IVM is a step behind than the normal IVF, what we are doing.
Right. As Dr. Sanjay sir rightly said, yeah, there's a huge difference between standard IVM as well as rescue IVM, firstly. Secondly, the very protocol for the standard IVM is such that we don't tease they're in dialogue, continuous dialogue with the primordial, granular cells, and there is a lot of changes that is going to happen, which is supported by them. But here, since it has already been denuded, and it is called as forced IVM as far as I feel, because just because you have denuded the COCs and you get to see that it is GV or M1, you are forced to keep because there is a less number of oocytes, or depending upon the case scenario, whether you have surplus oocytes or not. So the outcomes, as Sanjay sir mentioned, there are some groups which are shown that there are optimal results with like when compared to the routine IVF outcomes. But again, the point of reproducibility comes into the picture, which most of us is not able to reproduce the same results as of those groups. And I think, it is in the nascent stage or not, I don't know as of now. Even as all the panelists will agree with this, it is not. But maybe if you look at those studies which have come out with those groups, and if you look at their results, we don't feel that it is still in its nascent stage. But again, it is not reflecting in all the labs, right? So this is a question which is currently cannot be answered. And having said that, next question will be on the zona pellucida. So what is the physiological role of zona pellucida? Dr. Manisha, you're on mute, I think.
Dr. Manisha, you're mute.
Okay. It has already been answered by the previous speakers, because zona pellucida, the layer which is responsible for the acrosomal reaction to prevent the cell from polyspermy, and so it is actually the first layer where sperm and oocyte interaction takes place. So that physiological role we have already discussed. And the importance, as long as it is, you wanted to ask about the importance of zona pellucida, definitely we have seen that 4 different glycoprotein, they have an important role in fertilization. So it is definitely an important part, and we need to look at it at the time of doing insemination or injections. So
yes, wait, sir. What do you think about the role of zona pellucida? How important it is to look at the...
as Dr. Manisha already told everything, and previous speaker also told about the acrosome reaction and zona binding, sperm binding, on these kind of things. Definitely there is the role of zona pellucida. Even that selection of oocyte quality and everything, also there is a role of zona pellucida. So physiological role is definitely there for that, specifically that fertilization things and all the activities.
Mr. Bala?
I would like to extend this question to oocyte, from oocyte to embryo. So while selecting the embryos, also we'll be considering this zona pellucida, that thickness of the ZP. So because that oocyte part everyone has covered nicely, so we got to so many information. So ZP has a role in selection of embryos also.
Right. Hemant, what do you like to say about ZP?
Yes, we know the roles and importance of zona pellucida. Mainly, it acts as a receptor where you will bind the sperm to the oocyte. And other main important role in the zona pellucida exists, that is the inducers of the acrosomal reaction, and mainly the prevention of polyspermy. This is all the know, and already all the 2 other early speakers have explained detailed about extracellular setup and features. I think this is it.
Sanjay sir and Nancy.
It is a protective coat of layer that everyone has told, and it prevents polyspermy, will give you specificity, and it will also help in the cell signaling pathways, can regulate the cell signals, and definitely can help in further activation of the oocyte and the acrosomal reaction.
Yeah, and also
yes, the transpiration.
And first mainly is that if you look at the zona, it starts from the follicular genesis. It is there from that point of time, and it is carried out till the blastocyst. Once the embryo gets hatches, till then it has been covering the embryo, nurturing the embryo, and it acts as a protective barrier. The first thing, and second most thing will be whatever the receptor are based on that. Yeah, the most important event that occurs, that is fertilization, is because of the receptors based on the zona pellucida, ZP1, ZP2, ZP3, whatever the glycoproteins which are there. That is most important. That and coming to that, followed this, the cascade of events, it also prevents the polyspermy, the cortical granules coming and sitting over there, and hardening, zona hardening, which happens at the time of the sperm entry. After the sperm entry, will also act, it acts as a barrier for the polyspermy. And also there are a lot of transport that happens between, because it also is a membrane, right? A lot of things will come in, a lot of vesicle based things, the cargo, which has been the communication that happens from the developing oocyte and the outside environment is through the zona again. And the size and thickness, again, yes, it varies from oocyte to oocyte and embryo to embryo, which is also a paramount important. And similarly, the thickness is also like, is it good? The thickness, the thicker the zona, is it good? Or the thinner the zona, is it good? Of course, yeah, we get to see the zona thinning at the time of blastocyst, where before it just hatches, the zona like gets thinned. So yes, all these points are there. So zona is not that thing which we got to ignore. Yes, it is most important. And having said that, Akash, please take up the question. Dr. Akash?
Yeah, sorry. Awesome. Just to add on that, zona we are probably bypassing by, we have put on this as there's so many roles which a zona plays when it comes to a normal fertilization without ART. So there's so much of role which is being played, but we are probably bypassing it to a large extent, especially when we are going in for ICSI. And that's why we probably don't see role importance as such, because you're taking a sperm, putting it directly inside the cytoplasm. But otherwise, for a normal sperm, for a sperm to fertilize it with, if I say without assisted reproduction techniques, then it has to cross through this barrier, which would be the first one. Speciation has been told about, right? Species specific. Aquatic animals, they just lay their eggs outside, and there would be sperms of all sorts of species going around over there, right? And the sperm only from this particular species can come and actually fertilize it. And they're about the species to species. And there are some papers which say that your egg and the sperm, they are mutating these species recognition molecules are evolving at a much more rapid rate compared to your normal mutation, which is going on, and something called as concerted evolution, which is happening over there. Your dimeric, heterodimeric in terms of your zona pellucida is there. Your polymerization is over there, which is happening. Your slow polyspermy block is happening. So probably it's not happening. Zona is not happening in ART, but it's quite happening in the nature. So with that,
Dr. Ash, I would like to ask one thing here, because so many experts are here. Does anybody consider zona thickness before opting for any IVF or ICSI? Like if a zona is very thickened, then one should go for ICSI, or we can go ahead with IVF. Like Sanjay sir and all seniors are here. I really wanted to.
Yeah, what happens is we don't get to see zona as such with respect to IVF insemination. Hardly we get to see, because it is surrounded with the criminal cell. Yeah, so that is again, which we cannot clearly distinguish the proper zona appearance. So probably yes, with ICSI, yes, it is very much understood. We get to see that. But yes, in IVF, again, as we discussed, the expansion of oocytes, which plays an important role there, whether we can get access through the appearance of the zona or not. That's what I feel.
Okay, and how about because there are we have seen contradictory opinions. Like few people are saying thin zona is good. With thin zona oocytes can give us good fertilization. Whereas there is a paper by Dr. Rama Raju in which they have clearly mentioned that thick zona has more developmental potential in the oocyte. So what is the consensus here?
So if I can add to your previous question, we do split ICSI for patients. So I have not seen any correlation whatsoever. This is my personal experience, not from any paper.
That is important.
Not anything in terms of thick zona. We had two cases which I remember there, which was more thicker than 20 microns, where they usually take 18 microns as the limit for considered as thick zona. More than 20 microns also. it does not matter in terms of fertilization rate. And like the paper which you have quoted about Ramaraju et al., yes, it has clearly shown, because probably there's a variability to it which we don't understand. And when it is not thin, when it is rather too thin, probably you are subjecting the oocytes to much more insults outside if you consider in terms of protective barrier. That is my understanding of it.
But there is one previous paper where they have quoted if it is below 12 mm, it is good. So I have seen quite contradictory opinions while studying for this thing. So I think
we need large RCTs based on that ZP, so that can come to a conclusion. I think the data which is put forth, I think, is not sufficient, because the results are contradictory.
ZP has got more role to play in IVF, and we can't assess ZP in an IVF cycle. Probably that's the paradox over there.
Yeah. And I think the person who does more ICSI is more right person to answer this, because they get to see a lot of different type of zonas, right? The thickness of zonas. Yeah. Arrow number 7, please, Akash.
So something related to zona size, we are saying. So rather than zona size, if you can comment, is there any ideal oocyte size which would be targeting it when we see post denudation? Yes, we know there's a giant oocyte. Yes, those are one category which are at the one extreme of it present. But is there any ideal oocyte size? Hemant?
I say ideal oocyte size. Yes, we know that the normal oocyte shape will come up to 110 to 130 micrometer in size, and which is more than 150 or more than 135 or 150 micrometer. That is called giant oocyte, which is having the chromosomal abnormality. But by doing ICSI, it is most of the time it is very rare to find differentiate each oocyte having the same size of the oocyte size when when we performing the ICSI. But many now literatures and articles say, I mean, searching for yesterday, then what is actual oocyte size? Because I never thought about it. I always mind okay, giant oocyte we think on, or in this very small oocyte, then what is the actual size of the oocyte when performing is there any particular size they mentioned? But as we look at the data, they're saying 110 to 120 micrometer. Some of the data says 130 micrometer is having a good embryological developmental takes place, which is micrometer. It is 130. So
how would it be correlated? How would you correlate in terms of why size would be important? Say 120, 130 microns is a size where you'd expect better embryological outcomes as such. But why would size be important?
They worked in the different sizes from 110, they took it to 100 micrometer, 110 micrometer, 120, 130. In that, the larger of the cytoplasm, they calculate the larger of the cytoplasm, not complete the oocyte. The larger of the cytoplasm, which is coming up to 130 micrometer, having a good prognosis of embryo development. That is they are find in this study.
Okay. Bala,
I don't have any specific comment on this.
Shukla Saved, sir.
Yes. So, very good, Hemant. You have mentioned this size limit. Again, another group from Asada Clinic in Japan, led by Hiroyo Kitasaka, they have published a beautiful, in my opinion, it is probably a game-changing study, which was published in Fertility Sterility Sciences last February. And they say that anything which is more than 130 micron or equal to 130 micron is a giant oocyte. And this statement is very bold, because we know the giant oocytes are diploid. So it's not just the morphometric assessment, but they went on to see the spindle through the birefringence and polyscopy. And then they proved that, yes, they have studied more than 2.5 lakhs oocytes. And their incidence of such giant oocytes was 0.22%. So it's not just this thing. They even went further ahead, and they studied with the fluorescent microscopy. They studied the spindle size, they studied the metaphase plate distance, and with all this, they gave two this thing, because we all know there are two types of giant oocytes, one with just one polar body and which looks absolutely like an M2 oocyte, and another is with two polar bodies. So we know that these are the giant oocytes. So obviously we assume that if we have a two polar body giant oocyte, there must be two spindles, and we have M2-like giant oocytes, so it should have just one spindle. So they showed that the giant oocytes, like according to their definition, which is more than 130 micron, if it has one spindle, it is large in size. And if it has two spindles, they are normal in size, but since there are two spindles, so obviously it's a diploid oocyte. And therefore, to me, and again, okay, so I'm forgetting another observation of theirs. So they zoomed the, nucleus, the spindle, and they studied the kinetochores also. And they found that it is double in number, almost double most of the time. So average kinetochore number that they counted is something around 86. So this is mind-boggling study. So I believe if we use something very good imaging system and connected with artificial intelligence, and if that things, the moment we put the oocyte in the focus and it says, no, bhaiya, ye to zyada bada hai, isko hata do. So we can avoid many aneuploidies. I mean, why we go for embryo selection? We can select the oocyte itself with
Yes, very informative, sir.
So it is really wonderful paper.
Wonderful and scary, sir.
What it happens to me is, by the study you quoted, the study has been done very meticulously, sir. Like, they started with one question and they expanded to the next question, and they took it in such a fashion that step by step. And at the end, they concluded that whatever the bold statement they made, the oocytes which are 130 or more than 130 or giant oocytes. I think with the number of oocytes what they have studied, I think it makes sense.
Yes.
True.
Yeah. I think that's once again. Nancy, go ahead.
So this is very difficult to, how could you differentiate between 130 and 135 or 140?
Your micropipette.
Denuding pipette.
No, but 140 if you're using, and you have, sir is saying that anything above 130. If it is 135, will it not come?
Here comes the role of artificial intelligence.
That's what sir is saying.
Not everyone is having it right now, and now it is so scary. Whenever we are going to see something like this, it will always come to the mind that is there something which is abnormal, or are we doing something? Are we injecting something which is abnormal?
Just to answer Nancy's question, yes, there is something called as cytometry, where you can measure even a single cell. But I agree with your question, because we don't do that in regular practice.
Right.
Yeah. So yes, it becomes very difficult to choose which is 130 exactly and less than 130, which is more than 130 and less than 130. Yes, in that cases, I think we have to follow something called a cytometry for each oocyte, then go for ICSI.
I think we can have a microscope based on that, eyepiece based micrometer, where we just see it is there. I know, not there it is. This is just a immediate answer what I could think of, like while sir was going on about there could be so much variability within say 5 to 10 microns. So you can have a micrometer which is based, a line which is based on there, and at least it gives you some idea rather than in the dark.
We have a simple solution, Akash. We can use 130 micrometer. We should start using 130 micrometer.
But then
start fitting it.
But then your denudation pressures.
Yeah, I agree with that. Please, your denuding pipette size. So that we get
puppet say, and start culturing. I'm going to implement this thing. I'll start culturing those things in a separate droplets and jotting down those things, because that would be the reason behind so much fertilization failure. This is really thought-provoking.
Only thing for me would be I would be not comfortable with the 130 microns, but we can always use to check it. I would be rather more comfortable with 140. 140 damage to oocytes would go up.
Second, after stripping off the cumulus cell, then you can pass it to 130. You can check. Yeah,
I know.
We have to start with
it's kind of dicey over there. Practice changing, you may say. Practice changing, but possible.
Yeah.
There's a word of caution, Manisha, here.
Yeah.
Is that the the denuding pipettes that we are using, they are not precisely 130 or 140 micron. Keep it this.
Yes, that is also there.
So just don't rely on this.
Well, going to next question. I think this has been already discussed with respect to the PVS, the size and shape and the debris in that and the significance. So we'll skip this question. Yeah. Akash, you want to take the question?
So one more can of worms. What we don't know, what we don't see, ploidy status of oocyte. And this has got more to do with the root cause as such, rather than how do you assess. This question is, at what stage does it arise? At what stage would the aneuploidy arise in a oocyte? What are the common stages at which steps at which it would form? From it would change from being a euploid to an aneuploid. In terms of the haploid status.
In a meiotic first.
Just one more question left. Yeah.
Meiotic first.
Yes, at this stage of meiotic.
Meiosis 1.
Meiosis 1, meiosis 2, at both the stages, aneuploids can arise.
Wherever there is segregation, there could be a segregation error, and then could be a aneuploid.
Which would be more important? Which is the most responsible one?
The one distinction. At what stage? Yeah.
Meiosis 1.
Meiosis 1 and non-disjunction of chromosomes as such.
Yeah.
And post-meiotic errors.
Post-meiotic.
I think both are equally important. You can't say one is more important, something wherever it has happened, it is going to create an impact. And it could happen.
I'm not saying which one will create more impact in terms of an individual oocyte, but as such, when you see total your cycle as such, or you see across patients, which stage is more responsible for causing aneuploidy? Is it meiosis 1, meiosis 2, early cleavage, later cleavages? So,
Meiosis 1.
Meiosis 1 as such, which is responsible for majority of it, and meiosis 2 less as such.
Because there is a segregation of the sister chromatids there.
Sister chromatids over there. And it would be more in terms when it's in mitosis, say post-meiotic, it would rather give rise to more chances of mosaicism. Yes, always the chance of self-correction and all those things would be there, but still it would result in mosaicism. And aneuploidy per se, if you say, it would be meiosis 1 would be the one.
Unknown caller.
Next question is like, what oocyte factors are responsible for fertilization failure other than nuclear immaturity?
Oocyte activation?
Oocyte activation?
Okay. If you are talking about total fertilization failure, so it could be, or other than that, male factor. It could be from the sperm side and something, or total, because otherwise total fertilization failure is something which we very rarely got to see. Actually, we get poor fertilization rate, and for which oocyte can be responsible. But total fertilization failure, if nuclear immaturity is not there, then probably the oocyte activation factors, they could be the responsible factors.
So you get a patient of TFF. Okay, patient wants to go ahead with the next cycle, and they say, this is our last cycle, we can't afford another cycle, but we would like at least one of the gametes to be related to the couple as such. So which gamete would you advise to change in the practical scenario and the acceptance of the patient?
It is very difficult to say.
if you're talking about the practical scenario, in Indian scenario, people always prefer to stick to the sperm. Usually opted for the oocyte donors. But I don't know now what is going to happen.
Yeah. So the question was actually for individual oocyte level, what is it? But like say TFF, we have a very well-defined one. PLC zeta is the one which can, if there's deficiencies of it, acrosomal one, globospermia. So very few cases where we can say for sure this is the case, which is responsible as such. But at oocyte level, individually, one is nuclear maturity, no doubt. See that, because if it's not going to be M2 oocyte, its chances of fertilization will definitely be lower. Definitely below. Other than that, anything else, other than the cytoplasmic factors, anything which is causing to have a no fertilization.
Akash, again, the question of ICSI and IVF comes in picture. So if we are saying, because to me, it's the gold standard, the regular insemination IVF, or even the natural IVF, like not natural IVF, but natural fertilization. So we don't know much about the things which are happening inside the body. But whatever we have learned from the animals and other species, there are certain mutations that alter the behavior of zona. So they don't allow the sperms to enter, or they don't adhere to the sperms, or there are scarcity of the markers, or the total absence of the markers. So they don't fertilize because there is no entry of sperms. But as far as the ICSI is concerned, there are several other factors also. It's not just the how do you inject the sperm? But that should not lead to a total fertilization failure. That may be some individual cases or the isolated cases. But as you are showing here, if there are mitochondrial insufficiency in the oocyte, so this would lead to the less cyclic AMP and other pathways, the ATP generation, and therefore there may not be the whole machinery not working in tandem with the fertilization. And because I have experience with the failed fertilization oocytes, which were then studied with the confocal microscopy and GM-size staining also. And then we found that there are sperms that entered, but they failed to condense. So, or even the decondensed sperms, but then they failed to further activate the sperms. So lack of, the oocyte activation factors like
calcium.
The PLC zeta and other things. And sometimes even the sperms, they lack the mitosis promoting factors. So all these things you do not know with just looking at the failed oocytes. Failed fertilized oocyte.
And also, sir, just to extend the point, yesterday we came across a paper where we read about acrosome reaction much before the spermatozoa reaches the zona pellucida. Even though there is acrosome reaction is over, even after that they are able to fertilize and allow the embryo to develop. That is a very rare thing which we get to see, because as far as we know, the acrosome reaction is very much needed at the point of zona, just to penetrate the spermatozoa inside the zona. But those spermatozoa which already this has been lost, the acrosome reaction, even they are able to fertilize the oocyte, which is a very rare study we get to see yesterday, and we discussed more about it, and let us not go into details about it. And as rightly said, yes, cytoplasmic immaturity and male factor thing and potential mitochondrial insufficiency, premature chromatin condensation, because we get to see there are 4 times condensation decondensation happens initially with the protein histones, where in the spermatozoa, it decondenses and again it is condensed with the protamines. It is replaced with the protamines. Again, at the time upon the entry into the oocyte, again this undergoes again decondensation, where again they are replaced with the histones, and again condensation occurs. So it is like series of condensation and decondensation which are replaced with a series of proteins like histones and protamines. And any change with this also will affect the fertilization. So
absolutely, because we call it the cascade of fertilization.
Yes.
Correct.
So everything should go in a very well orchestrated way,
so that any one failure of any one event will eventually lead to the fertilization.
I like the word which Sanjay sir has used, orchestrated way, because it's actually an orchestra which is playing out. It is not one after the other, chemicals, but it is like, the fusion of the sperm.
No, it is
the release of this. Yeah. I'm starting with this. Like I'm starting from the point of fusion. Yes. Before that, it's the pH 20 and the Hyalase 5, those molecules causing the dissolution of the hyaluronic acid bases. The sperm passes through inside, gets attached, specific attachment to the zona, binding, acrosomal reaction happening over there. The sperm passing through the fusion of the oolemma and the sperm, which is still very much not known what actually are the receptors. So yes, some transmembrane proteins are there, proponents and those, but still we are not very sure about those. And then it gets engulfed inside. Then you have your decondensation happening over here, your protamines getting replaced by your histones happening over here, your rearrangement of the organelles happening over here, and simultaneously you have a metaphase to oocyte, the spindle which is having its own trajectory to follow, the polar body 2 being extruded out, again it is forming, then all these things happening simultaneously. So there's
again
so much of PLC zeta. Yes. Coming to PLC zeta over there, then it would cause activation, calcium exudation from the ER. Then you'll be having your anaphase promoting complex, which gets broken down, and then it will cause resumption of your meiosis. So it is an orchestra. It is so many things going on simultaneously. So we are still probably at the tip of the probable iceberg in terms of what causes fertilization failure. Though we are seeing 70-80% of our oocytes getting fertilized in IVF, but remaining 20% is still a vast open area as to what is causing this fertilization failure.
Yeah, having said that, I think, we're done with the questions. And we thought yesterday we were doing some research on this oocyte, evolution of oocyte and all. Then we got very important questions, like which we thought we'll mention this in the panel, so that this is the places where the actual research is happening with respect to the evolution of oocyte and the modes of fertilization. So, like, have you ever wondered the oocytes of humans and mammals adapted? When did this adapt to the internal fertilization? As we get to see, in the ocean, as we already discussed, Akash has rightly mentioned that external fertilization happens most of the times, where the ocean or the water acts as a medium for the spermatozoa, for the gamete to reach the oocyte and fertilize eventually. But when did this internal fertilization thing came into picture? Nobody knows about it. Still, a lot of research is going on this. And similarly, the $1 million question, the egg laying or live birth, which is first. So how does the evolution chooses this? And
I know the answer.
Yeah, so
it started in the Garden of Eden.
Yeah, right. And the evolutionary biology, they say it is the egg one, and then the live birth happened. It is from the egg, because they correlate with this the very ancestor of us. It is called as the winged fish or something, where it is the first ancestor for the vertebrates and invertebrates, which evolved. It was earlier, it was egg-laying fish, which evolved eventually to a fish that gives us birth to the live birth. So that switching over, nobody knows when exactly happened. Probably it was 500 million years ago. So which is a very long period. So that was I think one of the oldest fossils as we get to see. And so what is this primordial reason for this straight, reproductive dichotomy between the viviparity as well as oviparity? Still, research is happening in this way, in these areas. And when and why did the live birth evolve? This is already discussed. What is the reason? What was the driving force for the nature to adapt to the live birth process when compared to the egg laying process? So what could be a reason? Probable reason. Research is also happening in these areas. Having said that, yes, nature will never invest its single atom of energy into something that is not productive. Nature remains the greatest and the best creator of all the time. and the good, bad, and ugly is just a various degrees of classification, which are mainly human-made. Thank you.
Thank you.
Yeah, thank you, Sanket. And if I may add to it, I would like to thank all my panelists for wonderful answers. And what we had tried to bring out through this panel is, we might be reading about in terms of whenever we see of oocyte quality, we tend to correlate it only with the nuclear maturity or probably the cytoplasmic features over there. But there's much more to it. There's much more to it than what we tend to restrict ourselves to. We have seen through the panel that hardly we have discussed about those points in this panel, but majority was about something else, features, and which do matter, which do have a role to play. And nothing is definitive over here. There's nothing which is definitive that this is good or bad. So nature does not work that way. Nature does not work in terms of good, bad, or ugly. It just works. This is good. How is good? It does not waste anything. So when nature does not discriminate based on how the oocyte looks like, whether it's good, bad, or ugly, so neither should we humans discriminate, neither in the lab for using it, with certain exceptions, yes. And I would like to finish it with, if you ask anyone, like any mother, which is the most beautiful child, the best answer for this would be, the answer would come immediately, it's mine. So probably none of the oocyte is bad, good, bad, or ugly. With that, I would like to close.
It's a very human-made thing.
Well said, Akash. Well said, man.
Very human-made thing, because we categorize it according to our convenience. So nature doesn't discriminate anything with as such good, bad, and ugly.
It's a beautiful session, Dr. Sanket and Dr. Akash. And it's quite thought-provoking because we were limited to the take-home practical tips and tricks. And I'm glad to see that you are discussing beyond that. This is a very good initiation and very thought-provoking session. Thank you.
Yeah, one more thing I would like to mention. We read about something called as the three-toed skink, where earlier it was a egg-laying mammal. Again, it converted at some point of evolution. It converted to the one
live birds. Live birds.
Then what happened was one extreme fossil which the scientists were discovered was, they identified a fossil where they get to see 2 eggs plus 1 live birth.
In the same cycle, in the same litter,
the same litter. One developing baby which is already there as a normal developing hatchling, and other one are in egg stage. So what they concluded is, maybe the nature is going back from egg laying, live birth.
Evolution can't always be single-sided; it could be both-sided. Yeah. And so many things which actually we learned during designing of the panel as well. I mean, we were really
lost it actually.
Flabbergasted.
4-5 questions. We lost the thing and we started reading about evolution. We went to so deep that we started about searching ZP proteins, evolution of ZP proteins, evolution of this oviparity and eviparity. Then we thought, no, we have to come back. We have to finish the questions. Tomorrow we have a panel to discuss. Then that's how it happened yesterday.
Thank you, Bala, and thank you, Dr. Manisha, for that.
Thank you, sir. Thank you.
Thank you so much.
It was well organized. Thank you.
Thank you so much, Hemant.
Thank you, everyone. Thank you
so much.
Thank you.
Bala.
Shukla, sir. Thank you, sir. Thank you, Hemant. And thanks to our
Yes, Nakul here. Thanks for giving us an opportunity, sir.
Nakulji, please, एक minute.
Yeah.
Wait, sir.
Yeah. So here, iHERA announced one skill development workshop on advanced micro manipulation. And please block your dates, 14 to 16 April. It will be for limited persons. And there will be 14 experts from national, or we are trying to get some international trainers also. And there will be more focus on hands-on training with minimum theory. And there will be all type of micro manipulator to learn about hands-on practice, and you will get course material and as well as certificate of attendance. So this is the date, 14 to 16 April. Whoever is interested, please, you can contact on below email address on a phone number. And yeah, of course, Dr. Sanjay ji, please, vote of thanks.
So, thank you, Dr. Ved. And I'm sure everyone must have enjoyed the entire session, have learned a lot of things which are new, which are coming up. Our these youth brigade, as always they do. They have put in a lot of efforts to research themselves first and then prepare the program. And the entire team of iHERA is deeply indebted to all the participants, our speakers, our panelists, and our sponsor, especially Nikhil and his team. So thank you very much, and we hope to see you soon.
Thank you everyone. Thank you, Nakul. Thank you so much.
Thank you.
Thank you, everyone. Thank you, Emcure.
Thank you.
Thank you, sir. Thank you.
Nikhil ji, Nakul ji, what was the line number at the time of panel?
Just Mayan, can you?
अभी अगर लाइव है तो आप
online, if you can stop the online, if we can go offline.
Mayan, please stop recording.